No.
All right.
Well, with that,
All
right, well, welcome everyone to the first APIC meeting of the year. I'm very excited to see all of you. Quite a group in the room, and it sounds like some folks on the phone.
Quite a bit of people on the line.
So thanks for joining us. With that, should we jump into the education on CDIS? Or do we want to do introduction?
Oh, yep. Introduction, probably. That would be good.
Yeah. Well, I'm Jessie Bond. I work over at St. Luke's, and I'm the current president of the chapter.
I'm Suzanne, and I am a contractor, and I am the treasurer.
I'm Marianne, and I work at Big Memorial in Blackfoot.
She's one of our newest board members.
Oh, yeah.
I'm Debbie Cutworth, and I work at Howard County Hospital, the Soul IP. That's in American Falls, Idaho, and I'm a board member. New one, too.
Martha Jaworski, I work at Qualis Health. I'm also on the board.
I'm Anita Partridge. I work at First Choice Home Health, and I'm totally new to infection control this year.
Well, welcome.
Welcome. Marwan Saidar, Infection Prevention at Boise Campus, San Alfonso.
I'm Holly Williamson. I'm the IP at Avonmere Transitional Care and Rehab here in Boise.
I'm Kimberly Link. I work over at Central District Health Department, and I am the new past president.
I'm Kim Vermadal, Infection Prevention. I'm a board member, and I'm here at the Boise St. Alphonsus campus.
I'm Terry Noyes, Infection Preventionist here at St. Alphonsus, Boise, and I'm also a board member. And then we have some people, quite a few people on the line.
Yeah, do you want to introduce yourselves on the phone?
Hi, this is Jerry Hammond, Infection Prevention with St. Luke's, based on the Nampa campus.
Lauren Wilson at Living Hospital.
Medical Center.
I'm McAllister with St. Luke's at Boise.
This is Larry Sherman, infection control over at Valor Health.
Anyone else on the phone that we missed?
Heather Milligan from Jerome is here.
Connie Clong from Boundary.
Yeah, I think you can just...
Brandy Tillotson from Bear Lake Memorial.
Hello?
Okay. Hello?
Hey, this is Kathy. Kathy Beersford of St. Luke's. Hey.
Awesome.
I'll do that.
Alrighty, well, if we missed your name, if you could just maybe shoot Kathy Pierce an email so we can make sure we get you on the minutes. And then we'll get started with our first educational session for the year. And Kim Vermadal is going to give a CDIS update for us.
Okay, so I'm going to introduce Kim.
Okay.
So Kim has been at IP at St. Alphonsus for the last 2 years. Prior to that, she came from a small hospital in Alaska, 100 beds, in Juneau. So kind of an isolated little area up there where she got a lot of interesting experience with and big influx of, huge cruise ships and whatnot. So saw a lot of things there. Prior to that, she was in Arizona and worked in the emergency department and has also taught nursing in community college there. She has a master's degree and she is CIC certified.
Thank you.
Thank you, Kim.
Thank you. So I think this is a topic that no matter what your expertise is, we're seeing CDIS everywhere in this country. And I was
graciously able to attend the C. difficile conference in Philadelphia. Susan provided the funds to do that, so that was great. A little bit about the conference. It's kind of has a little bit of everything. It's heavily scientific-based with a lot of research. We had speakers from all over the world. We had people from England, we had Italy, every country. It was quite amazing, and so that was very interesting. A lot of IPs were there as well, and then a lot of the scientists couldn't agree on the best way to approach this problem. So I think that's good to keep in mind, because I think you'll hear as I go through this that a lot of people are doing different things related to isolation and testing.
Next slide. That's weird. It just worked before. Weird.
Okay, so I just have to press it harder. I'm weak. So when we look at what C. diff really destroys is our microbiome, and it's really a collection of 39 trillion microbes in our GI tract that really protect us from an incredible amount of things. And so that healthy kind of gut flora protects the body from disease. It precludes emergence of pathogens and MDROs. And we really want to prevent those changes to the microbial gut function. And so the C. diff disrupts it terribly, but then we treat people with antibiotics that destroy it as well. And some people never are back to their baseline. So they had at the conference 3 different speakers over the 2 days that talked about their experience when they developed C. difficile. One woman has never been the same ever again. One woman was in her residency as a physician and really didn't know anything about C. diff and when she developed it. And then a horrible story where a family was not told how they had to care for their grandmother in their home. So the grandmother got C. diff in a 3-bedroom house with 1 bathroom. Pretty common. When I grew up, we had 1 bathroom, not like everybody has all these now in facilities. The mom came to take care of her mother. She developed C. diff, and it was right before one of the daughter's wedding. And so when the person who was the speaker came to talk to us, she developed C. diff. And within a 6-week period, her grandmother and mother both were dead. And she had a long course of recovery. And she said not once did anyone tell them, we have 1 bathroom, how can you be safe? And so I think that's a really important lesson for us all. Terrible story. It's me, I'm weak.
Oh, they're waiting for me either.
If you're weak, yeah. Oh, I'll have to roll it. Okay. So the first thing I want to talk is about testing. So a lot of facilities are doing a 1-step test, but really the only thing where you're going to get a truer result, because nothing is 100%. We don't have a lot of really great testing that's telling us if it's really C. diff. But you really need a multi-step testing process. 1-step testing, about half of those processes are positives are not C. difficile infection. And I think an interesting stat that I heard at the conference, about 25% of CDI resolves on its own. And we know so many of us are colonized as well with C. difficile. And then we never want to test asymptomatic patients. And so I'll kind of use our St. Alphonsus experience that we were testing people that really probably were colonized and not a true infection. So if you're not doing the 2-step testing in your facility, I would highly recommend it. And you have to come up with some kind of algorithm that everyone can agree on. And this was just one of them. So with this algorithm that was brought up at the conference, basically the clinicians and laboratory personnel agree at the institutional level to not submit stool specimens on patients receiving laxatives and submit stool specimens only from patients with unexplained and new onset greater than 3 unformed stools in 24 hours for testing for C. diff. So whatever your criteria is, you all have to get together and agree on that. So here, if a formed stool is sent to the lab, it's immediately rejected. They're not going to try and test it. They're not going to try and guess if it's loose enough. It's just, it's gone from the testing. And then you have to decide what are you going to do. Some facilities are just doing the toxins, some are moving on to NAT testing. So whatever you decide, you really have to have that initial test and then a backup one to confirm that that really is CDI. So I think we don't see a lot of pediatric testing, but I guess it's increasing. That we had a whole speaker at the conference on pediatric testing, and most us as newborns are positive for C. difficile. There's been a lot of great research on breastfeeding and C. diff that if we are breastfed, we have a really lower risk of developing C. diff as adults. So for some of us, I guess it's too late. But there's really that high prevalence of asymptomatic carriage in the pediatrics. So anyone under 12 months of age, we should never be testing. And then really have to be very careful in the pediatric population of 1 to 2 years of age. They really need to exclude anything else infectious before that testing begins. And of course, we all know really the main cause of developing CDI is antibiotic usage. I'll tell a kind of a personal story. So I was an ED nurse for, 25 years. I hate saying all these time frames are so long. But I worked with a physician, and he would never give people antibiotics because he would tell them, no, that's a virus. You don't need that. And everybody else was writing, everybody who walked in the door with viral syndrome got an antibiotic. And they all got wonderful patient, they loved all the other physicians, but they hated poor Dr. Skinner because he would be like, no, it's a virus. Here's what you need to do. Get yourself some nasal spray. And I just always think about him because he was so ahead of the curve, And I think we're not doing a really good job about that. So the IDSA guidelines that have just come out really are talking about decreased length of antibiotic therapies for almost every condition. What was 10 days is now 5 days. So there's been a lot of changes. So if your facility is not working off those guidelines, that might be something you want to bring to your pharmacy and therapeutics, or if you have your infection prevention committee. At the conference, there was a speaker. So there's all kinds of subtypes of C. difficile infection, and some are more toxigenic than others. In the UK, they've eliminated the most toxic subtype of C. diff with stewardship. So they have a tight rein on fluoroquinolones and cephalosporins. I mean, they've totally eliminated in the country. It does not exist through stewardship. We obviously are not there yet in this country. There's been a 41% increase in antibiotic prescriptions in the outpatient settings by nurse practitioners and PAs. And I think that's not really a shocking number for us because if most of us, you don't see your physician a lot if you need to get in there quickly. If you're going to a clinic, you think you have a sore throat, you're going to most of the time see a PA or a nurse practitioner. So that's where you can really get your bang for your buck if you start looking at what's being prescribed in the outpatient setting, and we're doing that here, trying to do some education. But the great news is a 15% decrease ordering by physicians in this country. So I don't know how good of a balance that is, though. And I know those of us that work in the acute care setting, we're seeing so many people that are coming in with C. diff. It's on the increase, but it's usually a less severe infection if it's community acquired. But how is it spread, in those patients with any healthcare contact? 82% have had some kind of outpatient contact, not inpatient. So I know we think about, oh, I was in the hospital. I always tell the terrible story about someone who took one dose of clindamycin and developed C. diff. But it's really occurring in people that only had outpatient exposure, or, quite a few of those people had none. So it's really on the surfaces, and one of the presenters presented his research. So he did a community study on C. difficile acquisition, and he cultured the bottoms of people's shoes in this one community. And 39.7% of the people had C. difficile spores on their shoes. So for those of you that don't take your shoes off in the house, I used to tease my husband because he never lets anybody wear shoes in the house because he's a germaphobe, but, I don't know. I guess he was right all these years. I didn't tell him that, though. So it's out there. It's in the community. I think we're getting more environmental exposures than we probably think.
I just get a call.
So we do fecal transplants here at St. Alphonsus. Do you do them at Luke's? Yes. So it really, if it's used, they've done all kinds of research. If it's used kind of as the first line, it can really prevent reoccurrence. A lot of the failures that we were seeing in the past, it's like they had this fecal transplant, it didn't really work. Well, if people really didn't have C. difficile infection when we were doing the one-step testing. So people really had something they probably didn't need because they really didn't have a positive C. diff test to begin with. And there's some trials in process going on in some of the big research hospitals that you're diagnosed with C. diff, you're not giving any antibiotics, you're just going to get a fecal transplant as the first line of treatment to preserve that microbiome, because then you're never going to have those, kind of double hit of you get C. diff and then your antibiotics wipe it out even more, and it can take years to recover from that. And one company, I should have grabbed them. I didn't grab them. They had, you'll take 20 capsules. All the fecal transplant will be in a capsule. You take your 20 capsules, you're done. So I think that's, I know.
That's gross.
No.
It's going to capsule.
Yeah, so I think things are, it's really interesting to kind of hear about all these great scientific minds thinking about how can we move away from antibiotics for these treatments. But I think the future is closer than we think about for some of these. So there's vaccines and clinical trials. Those would be used for those people that are high risk. They're not doing really well with them, but there's one that's reached the phase 3 of trials. They're looking at new antibiotics that are very narrow spectrum instead of these broad ones that we do. There's 40 new antibiotics in development, but only one has reached the phase 3 trial stage. Some people were very blunt about it there. They said there's no money in it. There's no money in antibiotics. We developed something for cancer treatments. We can make a lot of money, recoup it. The antibiotics, not so much. So I think these people that are thinking out of the box about the fecal transplants and that sort of thing maybe are on the right track. There's all kinds of other research on other compounds to maintain the microbiome, and it was interesting. Some of the scientists just totally stood up and said, I don't agree with your research. It was kind of funny. And then, of course, extended tapers of vancomycin every other day instead of every day, they're finding are just as effective for patients with C. diff. And then the fecal transplant as the primary treatment. So I thought I'd share our criteria for testing. Everyone has it a little bit different. When I came here, people were like, they would order the C. diff because patients would come in and say, oh, I've been having diarrhea for 2 weeks, and then nobody would have diarrhea here, and well, then they would give a person a laxative. Well, of course, you have diarrhea now. So those were colonized patients we were treating. So the patients must have greater than 3 watery stools in the past 24 hours. That specimen must conform to that container. If it's solid, the lab will reject it. If we think it's ileus or toxic megacolon, we can consider a rectal swab. That doesn't happen very often. And then people need to have one other thing. If you think about being in the hospital, people have diarrhea all the time. There's new medications they're taking, their diet's been totally disrupted, they're not sleeping. Then you need to have one of the other, some kind of abdominal pain. Have you had any kind of antibiotic therapy in the last 3 months? Are they on any kind of gastric acid suppression? Because we know that's a risk for C. difficile acquisition. Any kind of GI surgery. Residents of skilled nursing facilities or over age 65 are at higher risk for C. difficile. We have a chemotherapy med-onc unit here, and those patients are very high risk for C. difficile. And then anytime you've been hospitalized, you're really at risk of that. And then if you've had a C. diff infection within the last 90 days, you're at high risk of getting another C. diff infection right away. So if people meet the 3 watery stools in at least one of those, and then we don't want them to have none of these. We don't want them to have had any kind of laxatives or bowel preps. Are there any other medications that are known to cause diarrhea? We know a lot of just antibiotics just cause some transient diarrhea. Of course, anyone that's on TPN or tube feedings, and is there another source that's likely dig into that. Oh, you've been camping and you've been drinking, out of the streams. People do that all the time. I'm so shocked. Yeah, that happens in Alaska all the time. People are like, well, it's so clean, it's coming from the mountains. Well, your whole family there has XYZ. Yeah. You just see the cute little deer and bears coming down to drink from the water and other things. We want to make that there's not any of that post-operative diarrhea that's expected after day, 0 to 2. And some people with short bowel syndrome, they have diarrhea constantly. So you want to take a really good look at that. And what our nurses do is really look at that. I actually look at every C. diff order. It's terrible when I say that. Every day to see if people still meet criteria, because they kind of linger on the order sheet. I don't know if that happens at your facility. We do the antigen toxin testing first, and then we do the PCR indicated. And remember, never want to do a test of cure. So you had C. diff, you had all your treatment. They said the time at this conference, actually, we always think it could be up to a month, but they said you could test positive for 6 months out. So then what do? You go, what do you do? Give them more antibiotics that they probably didn't really even need. So, and I don't see that this much anymore. It used to be, they wanted 3 samples and people wanted to do a test of cure. I see that not very common anymore. I think the younger physicians are up on the news. And then we have, patients, of course, stay shorter time in the hospital, and there's a little bit of controversy about when do you remove patients from isolation that have C. diff. Some hospitals have just gone to, they're in isolation the whole time they're in the hospital. But that's a terrible thing for people to be in isolation. The nurses, hate putting on all that gear, and you're very isolated in isolation. Research shows people get visited 50% less by the clinical staff because nobody wants to go into that room. So for removal, the person has to have completed at least 7 days of appropriate therapy. They have to have formed stools, and this sometimes is the sticking point where people don't get out. They have to be capable of performing their own hand and personal hygiene with soap and water. So sometimes we end up people staying the whole time here because of that third not being with it enough to do. Questions?
Well, I have one. In the assisted living, so many of those people, if they're lucky, they'll just get a little soap on their fingertips if they wash them at all.
Yeah.
And they just poo-poo everything you try to teach them about what to do, and their hand hygiene should be just like ours, 20 to 30 seconds, soap and running water. So what do you do with these clients in the ALF? They're not capable of that.
Do you have a liquid soap?
no bar soap is allowed, liquid
Yeah.
soap only.
Sometimes, and I don't know if you can change this because it's difficult to get product change. Sometimes if you can get the foam soap, at least you get more coverage. You know, it kind of really melts almost.
Have any idea? I don't have any ideas for that one either.
But
So what about,
a challenge.
I read something several months ago, if they have any emollients in the soap, it can leave the spores behind. And all of those soaps that we're familiar with, almost all of them at least have aloe vera in them. Have they done any studies
I haven't seen that.
Yeah, I haven't seen that.
No.
about the spores being
Yeah.
left behind with an emollient?
I haven't heard any of that. And I didn't hear anything about that at the conference as well.
Well, then I'm going to quit saying them then.
Now
I like
it's more the action of the, it's more the action of the friction.
Okay,
Good, I'm glad I asked that.
Yeah. But maybe, you could try you can get a sample of some foam soap and see if that, at least gives you more coverage.
So do you think part of the problem is just kind of an inability to get a lot of friction going, or do you think it's more just kind of a mindset
I think
that what
it's
I'm doing is...
mental, and a lot of these old people are using the wipes. To me, that is not adequate.
Yeah, because they're simple.
The body wipes, yeah. Some of it's physical, they can't stand at the sink.
Stand to get to the sink. I was gonna say, I thought that would be it, standing to get to the
That's
sink.
part of it. Part of it's just that mindset. So I keep, because I'm home health, but we see these people and then we're gone. And by the way, I'm recommending we all wear booties the minute we step indoors inside an assisted living. So put booties on. Take them off just before you leave. Because I agree, we're walking it out. Yeah. So I keep saying every time we see a patient, we instruct the patient in hand washing and we instruct the caregivers. And we just keep it up.
Yeah, that's what you have to do.
Okay.
Good
You just
job.
have to keep, pushing, and then, even if half of the people that light bulb goes on, that's a success.
Do you know if they do anything like promotion before eating or anything like that? Promotion of some kind of hand hygiene or...
Well, a lot of the facilities do. They'll have alcohol there at the door and say, clean your hands. I was at something in the Veterans Hospital just before Christmas, and they had that for all the clients. And some of them would take a squeeze of alcohol, and some of them just walked right by it. So we need that.
Does anybody on the phone have any questions?
This is Amy Bearliker. I do have a question. For your lab rejection criteria, how did you get to that point where it was consistent and part of their practice to reject those? And then what is their follow-up when they do reject them?
They call and say that this is a form stool and that then the order is canceled. And it says actually in the lab report, form stool, and then if you want the testing, please submit say diarrheal stool.
Rationale.
Yeah. And it's just, I think it was taken to committee, it was run through the lab, and I think just show, the research that this is the criteria everywhere, and not just in this country.
Is your lab consistent at rejecting
Oh,
samples then?
Everything gets rejected if it's solid. Yep.
That's amazing. Yeah, we don't even send them if there's any kind of form stool in them at all. We don't even submit them.
Yeah, I
to
think
the
that's
lab.
the way you can approach it too. Just, tell nursing, just don't even send it because
Well, you can tell them all you want, but
Yeah.
I feel like it still happens.
The lab we send ours to, which we're a lab, but we send to a reference lab for that, and they follow the Bristol criteria, and it's like a numbered criteria, and it has the
Yeah, it's got the
consistency,
picture.
and there's an actual picture, and so they use the number, and it has to be this number or it's rejected.
The lab should have criteria for
Oh, they do.
rejection and to it. Not worth doing the test if it's not the right specimen. And that holds true for all specimens, not just the disc.
And I think maybe if you have an antimicrobial stewardship committee, that would be a good place to take it because then they are treating people that do not need that antibiotic. So they're just colonized if they're getting a positive test. I don't know. That's a hard Change comes slow.
Yeah.
So I have a question, Kim. Did they mention anything about the future of C. diff testing? Because we know
Yes.
our current testing methodologies are not perfect, even the PCR, because we're picking up a lot of colonization with that.
There's like about 5 or 6 companies working on a one-step improvement in testing. Yes, there's all kinds of companies working on that. How far that is out, some of them have been fairly successful. Some are the best ones are only approaching like 90% accuracy. So we're away from it, but yeah, I think people are really working on that. Some kind of simple, easy test.
And was there any discussion or presentations on the future of reporting for a C. diff for regulatory purposes or through CMS, knowing that the current definition
Lab ID,
is subpar and not really a very good metric?
There was not any talk about that. What I do here when I teach about C. diff is, because I think a lot of people don't know, I tell them, okay, your patient had diarrhea day 1, 2, 3, you tested day 4, now this is a hospital-acquired infection. And they go, no, it isn't. The patient had diarrhea on day 1. And I said, well, we didn't test early enough. So I hit that really hard.
Reimbursement. So we just explain that we're not going to get our reimbursement if you test on day 4, and so they're testing earlier.
Yeah.
And we have lines, just this constant education.
Well, it's
and
not
like
3 days at loose stool, isn't it? Is it 3?
No, I meant
not 3 instances or?
yeah, but I'm just saying if someone came in and had 3 days of diarrhea and then on day 4 we tested it
instead of day 3.
So it's taken better history to see how long they had it before they came?
No, it's the CMS reporting is by lab ID, so it's when the culture is tested, the date of the test. It has nothing to do when the diarrhea started, and that's how we're getting penalized because we're sending it too late when we should have sent it early on in the admission process. And because they don't let us as IPs make a decision on
So
it.
I see every C. difficile test, I look at every order, I look on every chart, and I call if it doesn't meet criteria and get the order DC.
And that has worked. I know it is onerous,
Our
but
third
it has educated people as we go. And other education.
And now when I go to look, the order's been DC, the order's been DC. So the work I have to do now is way less than when I started it because people know. Or I'll call and nurse said, oh, I just asked the physician, we're getting it canceled. So, and we're not treating people that don't need antibiotics, but it's slow.
And we shouldn't have to do it that way, but.
I have another question. I hope I'm not.
No.
So I teach that a person who's had C. diff continues to shed spores for the rest of their life. Is that correct? Am I wrong in that?
Not necessarily.
They're not active spores.
Oh, I'm so glad I asked.
Because you can be colonized, but not.
But sometimes you have the vegetative state, not the spore state, because it has two different forms.
States,
I better quit saying that.
Yeah.
Okay.
Well, but if it works for you, I guess.
Well, it could. I don't think they
how do
totally
you
know that.
know?
You don't know any given person, but there's an average that, if I remember.
Yes, and it's longer than we used to think about how.
30 days or longer.
Yeah.
So you can say for a long period of time.
Yeah.
Well, my point is, those people need to be sure they're using good hand washing.
Well, they have done research that they can live on surfaces for 5 months, so you should know that.
Indefinitely.
But not properly cleaned.
Right, it's not properly
Right.
cleaned.
Right. The environment indefinitely, yeah. Okay.
So I was here. You mentioned at the beginning that there are oftentimes family members who are sharing bathrooms and they're not quite sure how to do things to protect themselves. And we at the health department will oftentimes get those phone calls with people with questions. Do you know of good resources, good websites to be able to send people to?
The CDC has a great website on C. difficile infection and how you can clean in your household to protect yourself. Yeah.
Is there an APIC?
Yeah, I think there is an APIC, and so.
But I think, I think a lot of people, they go to their provider and they're not told. It's like, oh, you have C. diff. Well, I had a friend who had C. diff, and she was still going to come here on vacation to see me. I said, oh, no.
Yeah, I heard that conversation. That was, I was like, she's not coming to visit.
So I think that's, kind of another piece of the pie that gets left out, and people don't know what to do. I mean, they would do it if they knew. So.
Okay, so I need to pick all your brains. So we have a lady who came into us. She's 87 years old. She came to the hospital for UTI, severely dehydrated, septic, not in a good way. Gave her antibiotics, developed C. diff, so she came to us for her long-term antibiotic management. So we had her, we ran her through her first course of antibiotics. The UTI resurfaced. The nurse did not understand the bigger picture, called the doc, got a UA, got the UA back, put the patient back on antibiotics. Caught it the next business day that I was working, which was 2 days after they'd been started on antibiotics. Placed on Vanco orally to cover for the old C. diff that we were still active with. Ran that course of Vanco, was off for 5 days. Loose stools developed again. So we changed to the other one that it starts with a G. No. Yeah. So she's just ended that course of the C. diff protocol. And good news was we stopped her up so bad she didn't poop for 4 days, which then forces us to have to then give her bowel meds. She finally had a stool. It was soft, not. So at that point, because she's now been off antibiotics for 4 days at this point, has a formed stool, not loose. So I went ahead and took her off of precautions at this point, because she's now been on precautions for, a month in our facility. So I'm like, I'm on a holding pattern with her to see what she develops next. Like I said, she's now come off of this. So I've got 5 days that I'm kind of putting her on watch protocol to see what she does. But at this point, what would you guys do next? I mean, she's a long-term care resident. She's not going anywhere. I'm keeping her forever.
So I'll just say from my experience, I've never had somebody who we've done DIFCID on get C. diff after we completed DIFCID. And we've done it on 2 patients who had chronic C. diff infections for greater than 6 months. So DIFCID's awesome. Okay. So hopefully it'll just work.
Right.
If not, I'd recommend a long-term Vanco taper.
Okay.
That would be where I would
She's done one of those already.
Or a stool.
Right.
But
Like
you've
I said,
already
I'm
done
kind of
antibiotics, so.
And then her age and stuff that they do it.
And I'll play devil's advocate, maybe. Did she really have a UTI when she came in, or was she just colonized?
Yeah.
Again,
At that age.
the thing was that she came off of the antibiotics for the first UTI the day before this nurse went and got another sample. So I'm like, she hadn't even fully cleared her first UTI, and then we're throwing more antibiotics at her. I'm like, so, but at this point, the train has left the coach house. I'm like, no!
That's a good option to see if that would work.
Mm-hmm. Well, like I said, we did that, and then, again, we're kind of debating whether it's the fecal transplant or if it's a long-term course of taper. So,
sounds good.
We've done as long as 2 and 3 month tapers before in long-term care residents.
Yeah, something like
it sucks, but it works.
Yeah, at $250 a dose.
Yeah.
Hoping for those cats.
Yeah. Exactly.
That's a great idea.
Are there any other questions for Kim or any other further discussion on C. diff?
I
have one question, because I'm so impressed at evaluating all the C. diff orders. How much time does that take in a facility this size?
Well, so we don't have a lot of orders anymore because people, they really, I think, are getting a good history. So I maybe have, maybe on a busy day, 6 to 8 orders to look at. And I have a really quick process that I can go through.
So you go in and you look at specific places in the chart
I have
for
these
your
3 places
information.
I look, and then I'm done.
And you just do that for Boise? Is that the process at other facilities or something else?
No.
Well,
We're hoping.
we're looking to standardize across saws, that's our goal.
That's a lot. So that
They don't have as many.
I'm pretty quick at
They
it
don't
now.
have as many patients, but quick at it.
Do things slip by on the weekend?
Yes.
Yes, I do, but on Monday I look for Saturday and Sunday, so I can sometimes catch it.
I think that is such a powerful way to approach this, because it's great to see posters and to get emails and all this stuff, but to get a phone call from someone, people do not forget that.
Yeah.
And they will spread that, and that's a great.
Just to know someone's looking.
Yeah.
Well, and you get a lot of new nurses, and then they're like, oh, I kind of forgotten that, because, when you're in a new facility and a new nurse, there's so much, you're just barely trying to hang on, and then it's that kind of reminder, and then people usually don't forget again.
And there's that tension between people hearing, oh my gosh, you gotta do it in 3 days to satisfy CMS, so there is a push to test, and then there's the pull not to test. And yeah, I mean, you can see why. That's great. Good work. Thank you. All right, thank you, Kim.
And then, it's not on the agenda, but the next thing, I think we do have some CIC questions that are prepared, so we can run through, and Martha, you're gonna do that? We can run through those.
All right. Oh, and also, did we put the survey out on chat, Karen?
I could do that now, probably.
Yes, I wanted
Since everybody is,
just to remind everybody that if you can, we want to make sure, actually we could do a check right now. Are people able to hear everybody in the room pretty well?
Yes, sounds great.
Okay. Okay, good. So we definitely want feedback on how the virtual experience is, because we're all sitting in a room and don't know that. So please complete that survey. And if you're in the room.
Some questions on the chat. Sorry, we didn't have it open.
Oh, let's look at that.
So, from Tatiana, or from Alex at the McCall Rehab, what are the recommendations for long-term care for isolation precautions? Any new criteria for long-term care? We really cannot isolate if secretions can be contained. A resident can perform hand hygiene or is cooperative staff assistance. They are able to assist.
Well, I think what's the problem with any of the isolation precautions, they're so kind of vague. They're not really cut and dry. Everybody agrees or disagrees on them. So I think what might be the best thing is kind of come up with a plan that's going to work for your facility and then kind of stick to it. I haven't heard of any new criteria for long-term care.
Yeah.
I work long-term care and skilled nursing. At our facility, we do contain them to their room if their secretions are not contained. So sometimes on like day 1, 2 of C. diff, if it's really bad, they're going to be in their room. Otherwise, yes, we do let them go out with really good hand hygiene. That's the biggest thing, is just telling them they got to wash their hands. And anybody who cannot wash their hands is contained to their room until they got formed stools for 48 hours is what we use.
And we put the enhanced precautions up for our staff going in the room, just so that the spores are maintained in the room. And so the staff observe, but the resident with good hand hygiene is allowed to come out.
Yeah, absolutely. If the patient does meet criteria to have isolation discontinued, do you move the patient to the room?
We do that here.
We do that too, but in long-term care settings,
It's probably hard to do that.
We just do a terminal clean on the room, but we don't move them. We don't have their room.
Well, and that's their room.
It's their
home.
All their things are there. Yeah. Yes, we have a deep clean done on the room.
Yeah, we.
Thanks for the question on the chat. We'll try and do better next time.
Is there anything else?
I think that's the only one.
We just have to remember it's there.
But, yeah, we had it. So this is Mary from Walla Walla. PA, thank you so much for inviting me to join your group.
Welcome, Mary.
Thank you.
Hi, everybody. It's nice to be here. Thank you for having me.
Of course. Let's go on to the CIC questions then.
Okay. So for people that haven't been to the meeting before, a couple of years ago, we started just putting up a few questions every month that are out of the CIC, study guide. So that's the certification in infection control. So we thought it was just kind of a fun way to help people get prepared if they were planning to take the test. So, and it's just kind of fun to throw out some topics. So we do share this, so every month a new person just comes up with some questions. So if anybody's interested, I know Marwan did several last year, but if anybody is interested, let us know and we'll put you in on a month. Okay, so I focused on environment of care. The appropriate hot water temperature for laundering linen is B. B. Okay, you ready? Okay. It's A. Well, I don't feel bad because I chose questions I didn't really know the answer to. It's not a win. So the rationale, of course, that hot water is an effective means of destroying organisms. They recommend 160. Of course, that's balanced with not ruining your fabrics, I'm sure. And then 25 minutes is the time. There was an article, I know I sent it around to the St. Luke's, I don't know if I sent it to everybody, that showed that C. diff spores are not always adequately killed with that, but that is a recommendation.
Our laundry goes to Luke.
Hey, I covered most of the valley with that. Okay, and then on the linen topic, a manager of linen services has contacted you for guidance regarding transporting clean and soiled linens in the same vehicle. Your response: clean and dirty should never be transported together. They can be if they are clearly separated. They can be transported together without need to separate, or the health department must be permission to transport.
I will narrow it down. It is not B.
Yeah.
Call Kim Lane, here's her cell phone number. I think she needs to see the health department.
I think they have to be
If they are
separated.
separated, B.
They are separated.
Okay, we're thinking B. All right. Let's see. Oh, very good. And so the rationale, I think this is interesting. They can be transported if there's functional separation maintained using physical barriers and or space separation sufficient to protect clean textiles from soil textiles. To me, that's a very subjective definition. So I would want to use a physical barrier.
Physical barriers.
But it's kind of interesting that they give that. Like if you've got a large enough trailer, put the dirty stuff in the front and the clean stuff. I don't know.
You need to make sure that
They can't touch.
Front seat and back seat.
Front seat, back seat.
you need to make sure that the technician that moves things do hand hygiene, otherwise they will touch dirty and touch clean.
Yeah,
and things over.
it's kind of a funny question.
Yeah.
But it's not even doing gloves when you handle linen.
Sure, yeah.
Okay, and then, this is Legionella, and actually I just ran this by a couple of people because I realized that the CIC study guide is maybe a couple of years old now, and so I was a little concerned that there may have been a change in this, but we'll go through it, and maybe somebody can pipe up if they know an update on this. So Director of Facilities informs IP that they did water testing, which is, of course, the first thing. Should they have? The water tanks of distal sites was positive for Legionella. The IP should consider disinfection of the hospital's water systems if there were no prior cases of healthcare-associated Legionellosis. IP conducts prospective surveillance, and there are no cases. The colonization rate for distal water sites is greater than 30%. Or the hospital risk manager asks for disinfection to be completed.
The only answer can be C.
Yeah.
I don't know.
Okay, well, questions that don't.
The IP should consider, that means.
Well, the one thing is you never want to test.
Yeah,
Right,
yeah.
Problem.
Right. Yeah.
I don't think it's A at all.
Right, yeah.
No, and I've seen a couple of folks on the phone say C as well.
Yeah.
Yeah, I think it's C.
Okay, let's go. And so I think that, interesting, the thought process that went around the room was that you eliminated the rest of them.
Yeah.
So, just as far as, I hate to talk like this, but as far as test-taking, processes, that's a really good way to approach a question like this. So, no, never.
You don't want to just be testing.
Right. So, but apparently at the point that this was, these questions were put up anyway, that is a reason. So the rationale is pretty lengthy for this one. That's on the next slide. So basically, they did talk about how to, superheating, flushing with hyperchlorination for short term, copper silver ionization, and if anybody has updates, please let us know. And then chlorine dioxide as a promising alternative. And then they talk about when you should consider testing, and it's really only if you're seeing cases is when you ever would. And they have to be healthcare-associated cases. So if you happen to get somebody that had it from the community, that doesn't even count, right? So that you really suspect got it in your facility.
Martha, do you recall the reference?
It was the APIC textbook. And I thought, I should look into this, and I did not have time. So.
And the last time I looked, I didn't think there was an official recommendation on, other than if you have cases or suspected cases.
On colonization.
Yeah. But I didn't know that, as far as a set number of positive cultures that you would then act on. I can't recall seeing anything like that.
Yeah, and like I said, it's from the APIC text. And John, are you on the phone? John Herding? I thought I heard your name. Because I know he did.
He was.
He's done a lot of work on this recently. I thought maybe he would know that, but. That's it.
Yep.
Good questions, Martha.
Yeah.
And I'll be happy to do it next month.
Oh, great. Thanks, Marlon.
Doing that. Well, there was another chat. There was a chat that popped up.
Okay.
Is there something above that, Brent?
No, never. It was for transporting clean and dirty together.
Brent, is that an updated rule or question? Yeah, it's being, they are really separated.
Maybe we need to revisit some of these questions.
Yeah.
Can you hear me? This is Brent.
Yeah.
Yes, I don't know. It's just in my 20 years working in nursing homes, that's where I'm coming from. You never, ever transport them together, ever. I can't cite the code or anything, but it's if you really want to get in trouble and get a citation, just go ahead and do that. And if you just think about it, it just doesn't make sense to transport them together. Even if you separate them, like was brought up in the discussion, how you just can't do it very well. So I've always taught just keep them separate. Just keep them separate.
Yeah, I have a bit of a problem figuring out when your circumstance would be to do that. I guess it's if you're dropping off something and then picking something else up.
Yeah. And going to multiple locations.
But, yeah.
I'm thinking St. Luke's might have this when it comes to the launch service of the truck. One going out, coming in.
But I don't know.
So do you do it?
We went and did.
We
I went there.
I was gonna say,
Yeah.
and if they're in those cars with the covers over them, I mean, they're totally hot.
There's no belief like them by now.
Okay. All right. Any other questions on the line or on the chat? Here, I'm going to roll my back. Thank you for using the chat. What else do we have?
This is Mary. This is Mary from Walla Walla. I logged in late, and I was wondering if I could see the C. diff presentation. I don't know if there was a PowerPoint or something. That was really good information. I'd like to see it because I missed quite a bit of it. So.
Yes, the presentation should be posted on our website. And if it's not, I'll make sure that it's on there.
And then we'll have the recording as well once it's over, I'll get a link and then I'll send it to Kathy, the secretary, to post so that you can listen to the whole presentation.
Yeah, so this year we are.
I haven't logged on to your website or anything yet, so I'm new to everything. That would be awesome. Thank you so much.
Yeah, we'll send out a link. We can send out a link to our website just so everyone can find that. And then, as Terry mentioned, this year we are trying something new. We're doing the WebEx, and we are recording all of our educational sessions too. So if you can't make it the day of, you can still go onto the website and listen to the presentation and the discussions that we had.
Way cool.
Yes.
Awesome.
So next on the agenda for the educational portion is roundtable. Does anyone have any roundtable items for discussion or any questions you'd like to throw out to the group?
Suggested topics for future education.
Okay, any suggested topics for future educational sessions that anyone's dying to learn about or dying to teach?
Exactly.
This is Mary. I have something that I've been looking into that I'd love to get answers from. We don't have an ID doc at my facility, so sometimes I'm left researching things left with big questions in my head. And I'm looking at hepatitis B labs and trying to differentiate between acute and chronic. And seems to me you have to order the core antigen for that and look at IgG and IgM, look at both of them to see. And so if anybody has information on that or wants to present me with the answers, or if I get the answers, I'd be happy to share them. But if that's anything anyone's interested in, I'd love to see that opened up for a topic. Hepatitis are so confusing, so.
I know our reference lab is ARUP in Salt Lake City, and if you just go to their website and in the little box type in that, there's a link that does an algorithm, and it says, it kind of goes through the testing and what it says. I don't know if that'd be helpful, but it might be. And CDC is always my go-to for that too.
The CDC has a really good algorithm that you can click on if you put just Google, punch in hepatitis and it'll kind of set you down the path.
I didn't see the algorithm, but I'll go and double check for it. Sometimes those things are buried in those CDC sites.
Yes.
If that is a topic everybody interested in, I'm happy to present about because I'm kind of also struggling. I'm trying to learn myself.
I'm wondering if maybe like a general laboratory session would be good. Kind of, just the lab basics, like throwing some micro and then interpreting and testing and whatnot.
Yeah.
You know what? Maybe the two of you could co-present. We have a lab person here.
Yeah.
How about a co-presentation?
I have no problem,
Maybe. All right. Well, we'll think. Yeah, we'll work it in.
Yeah.
Right. That's a great suggestion. Thanks, Mary.
Cool. Thank you.
Sure.
I'm glad I made a good impression on the first time, just showing my sharing stuff.
Now you'll have to come back though, because now you'll have
well, this is great. This is a great group to bounce things off of and ask questions. This is wonderful. I'm definitely going to try and come back to more. Yeah.
Great.
So we have a couple things on the chat. I think Kathy asked about the Hep B, and that was Mary.
Mary, what's your last name?
It's MacFarlane, MacFarlane. You can see me in the chat there.
Okay,
and
thank you.
Before I mute myself again, not to butt in too much on my first time, I'd be really curious about how flu is going on over there. And I'm just going to mute, but you can do that at the end or whatever. I'm just going to mute myself now. Thanks so much.
There's her name right there. Mary McFarland right there. Okay. All right, and then we had another question in the chat. We did post the APIC link as well, to the APIC website, Intermountain chapter. Something else just came in. Okay. This is great.
Yep.
Okay, PAPR versus N95, practical experiences and when it would be appropriate to implement airborne isolation for RSV and influenza outbreaks, how to be prepared as a facility.
There was one more up above about copper and something ionization. One more. There you go.
Oh, yeah.
We are not, St. Luke's is not using
We're not using copper.
No, we're not
We're
either.
not either.
Ionization for what?
Is this for disinfection?
Cleaning. It's apparently really expensive to retrofit your pipes if you don't already have it.
Is this a water?
The water treatment.
Some newer facilities are
building
doing
it
it, but it's cost prohibitive.
Illnesses.
I think the only time you would even consider airborne isolation is if you had a novel influenza outbreak where you didn't really know what was going on.
Yeah, the CDC does recommend airborne for flu.
Yeah.
But RSV would be contact droplets.
Right. Okay. And someone was asking about, did we answer the question about flu in our area? We haven't. We're seeing an uptick, but in this last week, there's been that outbreak and notice in the schools.
What I've done is I sent the information about measles out to every one of our physicians. We're doing a reboot on our clinics and our emergency departments on think measles. I put a picture out of measles because when this happened in Alaska, a lot of the physicians had never seen what measles looked like, and so we're just really being hyper aware of rash, unvaccinated, and just did a whole big education thing, tons of flyers, and to be out on the lookout is what we've done here at St. Alphonse.
Trent, are you thinking measles as a future educational topic? Or were you just wondering what everyone was doing?
Yeah,
Okay.
I think it'd be just a good one to kind of, especially like.
Oops, I went up the rail.
Well, even if I think a good thing that would be very tricky that luckily we haven't had to deal with in Idaho would be, patient follow-up if there is an exposure and just, tracking and tracing patients.
I know for the influenza that I just yesterday talked with the Southeast Idaho Health Department, and they send out every Monday emails and gather the information and let you know what's going on. So we had seen in January a definite, we didn't have any, we're small, but we didn't have any in December, and we've seen 10 already in January. So it's a definite upswing. Flu Bs. Or no, flu A's. In November, we saw flu B's. January, it's being flu A's.
Yeah, within the St. Luke's system, kind of more of a delayed flu season and start to see an uptick in December, and we're seeing predominantly H1N1.
That's what we're seeing. And we're seeing
but we're definitely on the rise.
A lot of RSV.
And we have a lot of
RSV. Wow.
It's in the race.
Yeah.
We're definitely more RSV than flu right now, too. We've had 0 flu hospitalizations and all the RSV hospitalizations.
Wow. That's good to know.
Yes. So I will put in a plug. So the Health and Welfare, kind of out of Susan's program, they do surveillance statewide for both flu and RSV. So for flu, the website's pretty easy. It's flu.idaho.gov. It's updated weekly on Fridays, having to do with the surveillance that's going on around the state. So it's a great resource. And then also from the Health and Welfare website, you have to dig into the diseases and conditions portion, but there is information as far as statewide surveillance for RSV as well. Perfect. Thank you. In Washington, yes, we know. Yeah.
Perfect.
Okay. All right.
Okay, any other roundtable items before we end the educational?
This is legal.
Hey.
And I wanted to see what the group thought about the issue we were talking about yesterday, where patients who have had a positive tuberculosis skin test, and then they get an order for a test x-ray to follow up, whether or not any kind of precautions are being applied
when that patient's being handled in the kind of an outpatient setting like that in radiology? Does anybody have any experience with that?
They're not contagious, they're not infectious. Yeah, only if they had respiratory symptoms.
Well, I guess the question is, would it be the responsibility of radiology staff to screen every patient coming in that situation for respiratory symptoms, and is that within the scope of their job?
Well, if you thought someone had respiratory symptoms, then you'd be thinking they had active TB, not latent TB. So,
but the question is, I guess, how are those radiology
I mean, I think they should be asking that should be the screening question to the physician that's ordering the test for them to come in. Mm-hmm. Do they have symptoms of pulmonary TB?
I think we can all agree on that. I just wonder how much trust we should have in the physician ordering the X-ray to have done that prior to, or if they did and they were, positive for symptoms. Make sure.
Well, the X-ray can ask the physician, right? I mean, that would be part of your.
We don't have a lot of TB in Idaho.
Mm-hmm.
At all.
If it's overall general respiratory, then, like we have our cover your cough and your masks and stuff at the admissions, that's at the front entrances. So, if it's respiratory and it goes through admissions, they could, they could ask them if they, think that they're having respiratory problems, that it might be a good idea to put on masks. Some of our patients refuse, but you might suggest it.
But I think, when they're actually taking making the appointment, that should be where the radiology folks ask the physician's office, does the patient have pulmonary symptoms before they even get there? They're giving them that other information.
Is how the workflow happens often. I think it's like they put an order in the system and, whoever shows up at whichever radiology, at least within the Luke system, I know that that's a possibility. You can go to this place or that place or the other place. The system has your order. Go get your X-ray.
Well, I think the doctor needs to have some responsibility. Like if he see the patient, if he or she see a patient with other PPD, have a night sweat, fever, cough, he needs to document and call the technician beforehand.
That patient should be going there with a mask.
Yeah.
Right.
And if there's no sign of symptom, he needs to document like there's no sign of symptoms, just positive PPD, we have suspicions, probably latent, so the technician will know. So I think that's the communication should come from the doctor. The doctor needs to be educated about that, how they do the communication through the nurse, through themselves. I don't know.
Well, and we've walked away from the chest X-ray on our patients who either have a positive history or that their first TB test, we actually do the blood test as opposed to the chest X-ray.
Right.
Quantiferin.
The quantiferin test. So we don't even bother with the chest X-rays anymore. We just do the T-spot.
And even PPD, like I came from Iraq, and it's routinely to give the BCG vaccine, which give false negative PPD, I guess. And most of the Middle Eastern, North Africa, they use that routinely. So any refugee immigrants that come here, they go to refugee clinic, they test them for PPD, they will show positive, they will give them 3 months medication.
Oh, wow.
Yeah.
They've actually, in our local refugee clinic here, they've pretty much switched over to using T-spots for that exact reason, is that you have that positive result on a PPD. So T-spots specifically, so that we can get around that. Yeah.
How effective is it? The BCG.
It is effective. It is effective there because they give it to you, and I think they give you another boost dose, if I remember. And we have huge TB clinics because in Iraq TB is endemic there.
What about the military personnel or people who've been in the military and then they'll test positive if a lot of them have been immunized?
It depends on the deployment area.
And so you check that?
Yeah. So if you go to Europe, for example, in Germany, they don't do that. But if you go to Middle East, Central Command, that's when you get certain vaccinations that other group doesn't take. Hepatitis B is big. they give like everybody probably, you know, vaccination back and forth, but that's sorting all together and different things.
But BCG isn't used in
No.
the States.
Yeah. It's not routinely. I remember the flu vaccine in the military, they put them as a line, and you have like, yeah, you move through the line, you know, you just show your shoulder, and yeah, it's funny.
Not to the guy getting it.
Alrighty, well, that concludes our educational session for the day. So thank you all for joining us. Great to have such a large group. We will take just a short, like 3-minute break, and then the board is going to meet and have our monthly board meeting. So if anyone wants to stay for that, you're more than welcome.
Yeah.
Terry, is there a way to get,
And if you want restrooms, they're that way on your left.
is there a way to get like the chat captured or,
Sure.
I
I want to know who attended.
yeah, that's